Good afternoon, everybody. My name is Rosemary Hannum. I'm the director of the Sandra Rotman Center for Health Sector Strategy here at the Rotman School. And our center is very pleased to be hosting tonight's panel event. This is the first in our digital health series. And the title is Looking Ahead, What's Next for Digital Health in Canada? Although this event is taking place virtually, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, while we are meeting virtually, Toronto is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Well, hello, everyone, and welcome. We have a terrific panel lined up for you tonight. Get ready for a candid discussion with 4 experts who will lay out the current landscape in digital health in Ontario and across Canada and weigh in on where we're headed. Our host and moderator tonight is Will Falk. Will is a senior fellow at the C.D. Howe Institute and has appointment with us here at Rotman as an executive in residence. Will is going to take it from here, but just before he does, a few words about our center. We're supported generously by the school and the Rotman family, and we focus on 3 main areas: research and thought leadership, educational programming, and outreach activities like this one, which we organize on behalf of our students who are pursuing careers in healthcare management. And just a note on our educational programming, our Global Executive MBA for Healthcare and the Life Sciences, which is our executive MBA designed for healthcare professionals across the sector. It's now entering the next recruiting cycle. Our 5th cohort starts in a couple of weeks, so we're now looking ahead to fall 2023. So if anybody's interested in an MBA, please have a look at the link I'm going to put in the chat. And consider sending in your application early. We have lots of merit-based scholarships, but they're most generous early in the cycle. So we'd love to hear from you. Okay, and with that, over to you, Will.
Okay, and thanks, Rosemary, and thanks for everything you do to make these happen, and to the Sandra Rotman Center. As those of you who have been part of this in the past know, we do this series over the course of 4 evenings during the academic year, 2 per term. The second one, I'm pretty sure, is on November 2nd. And we'll talk about artificial intelligence. The 3rd and 4th, Rosemary and I are kind of figuring out exactly what we'll do, but the 3rd one is usually the startup one, and the 4th one, I think this year will probably do something again about the economics of primary care and communications. This first panel is very much an overview panel, and we've got quite a powerhouse group here to do it today, and that's reflected in the really great attendance. So I'm going to just dive in, give you a brief introduction to the 4 people. The speaking order is going to be Mark Casselman, who's the CEO of Digital Health Canada first. Zayna Khayat, who's been my colleague at Rotman for many years, who's Vice President of Client Success at Teladoc. Sonya Lockyer, who's a grad of the Rotman program, she thinks in 2007, and we're not going to necessarily check it, who's the VP of Care Centers and Pharmacy Services and Wellness at Telus Health. And finally, Sacha Bhatia, who used to be my boss over at Women's College, but is now running population health and value-based care at Ontario Health. So it's a great group of 4. And Mark, I'm going to go to you to get us started, please.
Well, great. Thanks, Will. It's a real pleasure to be here with this fantastic group, and certainly with all the amazing participants. I can see the names filling in online, and it's quite an amazing group we've got with us. So look forward to great dialogue in the conversation. My job here today is to kick off this conversation and talk a little bit about an overview of digital health in Canada, lay out some of the definitions. I'll share with you briefly some of the key themes strategy-wise from province to province that we're hearing about from our members and key stakeholders across the country, and then drop a couple of big questions for the group here that we can explore as we continue on. So as Will said, I'm the CEO of Digital Health Canada. We are your national association that connects, inspires, and empowers professionals in digital health that are shaping the future of health in Canada. And, really, when we talk about digital health, there's a couple of definitions that I really like to refer to. One of them is digital health is the convergence of digital technologies with healthcare, living in society to enhance the efficacy and efficiency of healthcare delivery, making medicine and care more precise and personalized. The second is digital health is a multidisciplinary domain involving many stakeholders, clinicians, researchers, scientists, vendors, innovators, and a wide range of expertise in healthcare, engineering, social sciences, public health, health economics, and data management. So I love those two definitions because we've got two key themes. Number one is convergence, and number two is the multidisciplinary domain. The thing that I love about this area, this domain area, is that it really requires many perspectives to come around the table, not to solution, but just to scope out the problems we face collectively, whether it's a local challenge, whether it's a provincial challenge or a national challenge. And all those perspectives are required. We're here a lot today about digitization, the balance of virtual, of physical environments, the requirements that we're seeing across our country, how we're integrating solutions together and working to do so. But ultimately, it's that people element that's required to converge and come together so that we can scope those out and bring those many perspectives together. You know, recently we sat down with our Chief Executive Forum, which pulls together leaders from across Canada, and we explored the question about, are we in a strategy gap? You know, as part of our overview of the Canadian landscape, coming out of 2 years of heads down work, focused on the problems at hand, ensuring that we're able to deliver care to the patients where they need it, when they need it. You know, are we coming into a space and time where we've been so focused on what we have right in front of us that we've really let strategic planning as an exercise and as a practice lapse? And so we really brought forward provinces to share with us their strategies. And I can tell you, it was such an enthusiastic conversation. The big takeaway before I get into some of the themes for me was how aligned across the country our ADMs are, our leaders in charge of the digital health strategies in each of the regions. They've spent a lot of time together, virtually of course, over the pandemic, exchanging, sharing best practices, and taking investment from one province, what's working, and applying that to another province, which has really developed a high degree of trust. If you hear a lot of speakers in our space right now talking, one of the key observations is that innovation, healthcare, health technology, digital health, it really only moves at the speed of trust, the speed of people and their trusted relationships. And so, you know, our ecosystem is strong from the standpoint of connected individuals coming together and very, you know, maturing leaders in the space of digital health. A few sort of key areas around our Canadian landscape that's happening in front of us is, you know, number one, data sharing, bringing together systems, devices, applications, and people, almost every province. And we heard just the other day from Ontario, from Quebec, from Newfoundland and the Atlantic provinces, as well as BC, had this as a pillar, a cornerstone of their strategy, to the point where the installation of solutions and systems is really focused on the back-end data business model, producing data that can be used, policy challenges in terms of how we'll share that data and connect it across the board. But that's a core element that's shared across the country at this time from a landscape perspective. A second is modernizing the investment in our technologies and really looking at, you know, how and where we're investing in digital solutions from an infrastructure standpoint. One of the questions I'll land on here in a moment as we close out is really balancing the investment in physical infrastructure, buildings, you know, and physical infrastructures, physical spaces with the investment in digital. We're still not at a point where strategically we're exploring both of those questions together from the standpoint of, you know, building the infrastructure. And so there's a lot more to be done from that perspective. I've had some conversations very recently on this topic with leaders in both retail as well as banking. And the balance between what's happening in that space and how they're connecting those environments is a critical piece. And I know we'll dive deep into that with some of the experts we have here today. Patient access, and most importantly, activation on digital channels and across omni-channel is critical. We're putting more omni-channel opportunities in place than ever before, at a faster pace than ever before. We need to ensure we're activating patients across those channels and balancing the two components. I've heard it phrased as, what is our target? Is it better access for care, or is it access for better care? Which draws us down two paths, to specialty services or primary care services. And those can be, a deeper dive and explored as we go into our further conversations here today. And then, of course, our healthcare human resources challenge and using digital solutions, digital thinking to address those. We've had some fantastic conversations and leadership recently across the association on the use of AI, the use of healthcare bots, many of which have occurred across multiple provinces through COVID, engaging citizens and creating access, and also finding opportunities for clinicians to be able to practice at their peak. Whether they're practicing 3.5 days a week, 4.7 days a week, practicing at their peak, making sure that every clinical, allied health, physician, nurse leader, et cetera, has that opportunity and is enabled by digital systems and not encumbered by those. So as we walk away here, I'll leave you with one final question. We'll talk about that investment aspect in digital, but from a broader perspective, I think one of the things that we're advocating for as a larger community is the continued investment and growth in investment in digital infrastructure generally, for individuals across our wide and large country to be able to connect wherever they may be to those digital services. We need more access to infrastructure, technologies, mobile, and always on, affordable internet and connectivity for Canadians wherever they may be. This is a great meaty conversation, Will. I'm going to pass the mic over to you to share with our next ideator.
Mark, you've been on this journey for about 20 years, and you talked about the multidisciplinary aspect, so this may be a hard number for you to come up with, but you have an idea from Digital Health Canada's point of view, roughly how many people in Canada today spend half or more of their workday worrying about digital health issues at this point?
We don't have that number. I would be hard pressed to imagine it. What I can do is, in my mental Rolodex here, go back to the last study, which it was pre-pandemic numbers, 2014 to 2019. And at the time it was estimated there were about 40,000 professionals who were focused on, digital health. At that point, it was actually defined as health informatics. So it was a more focused segment of individuals, because we know there's a lot of digital health professionals who don't necessarily affiliate as a health informatician. So I imagine that number is probably 3 to 10 times that size at this stage.
You've done a lot to make the industry more comprehensible. Getting rid of the informatics and changing the name from coach have really been blessings, Mark. So thank you for that. Let's go to Zayna. That was a joke. I didn't even get a smile from anyone. Okay, Zayna, you're next.
Yeah, Mark, I just threw a question in the chat for you to answer while I'm chatting. So maybe a bit of context. So, I am a professor teaching the health innovation course in the MBA program in healthcare at U of T at Rotman. But I'm going to kind of bring more of the lens of the role I've had for literally a year and a day, which is with Teladoc. And in Canada, you might not know, but Teladoc is the biggest virtual healthcare company in the world. We're in 170 countries, 600 health systems, 12,000 employers entrust us to support 76 million people to give them their care, 50,000 clinicians. We're a health delivery organization, billions and billions of data points, and it goes on and on. So we're really the tool maker, and I wanted to be immersed in this environment of what does it mean to deliver tools at system scale to enable healthcare systems to modernize. And that's what I'm, on an intense learning curve on. And so I was recruited a year ago to bring these capabilities to Canada. So let's go one level up from Mark and kind of getting us to some definitions. So back to the basics. What's the difference between health and healthcare. And then what's digital's role in that? So health, anyone can define it the way they want. I like to think of it as it's kind of like the result. It's not the absence of sickness or, identifiable disease or anything right now, but really it's what you and I do every day for ourselves. 98% of the time, it's you. Healthcare is when you can't do that, you choose to outsource that agency to someone else. And these are trained, licensed, amazing professionals called the health workforce, because you can't do that for yourself. And that's a small percent of the time, but that's what we're obsessing about. And so when you're going to do that and outsource your care of yourself to others, there's a few things that really, really matter, right? Access. We just heard Mark talk about it. Can I even get access to that? And by the way, we're paying for it. You want time to be heard, or you want to know you were heard in a way that is going to lead to the third thing is something action is taken to be resolved. So you want access, you want to be heard and have time to be heard, you want an action as a result. And then the last I'd say is you want to have trust that you're feeling valued and included in this process by this person and this service you're now entrusting that you've outsourced your agency to. And that comes through being very transparent, authentic, and benevolent, an intention of kindness from the people helping you. And we've been reminded of the lack of that intention, on the anniversary of a First Nations Inuit Métis woman in Quebec 2 years ago. So what's the role of digital health? So I would say, if the goal is access, transparency, trust, and to be heard, then that's where I think about the excitement and the promise and where it's got to go. And so in my view, there's three real promises of that. One is on this access side and transparency. Well, this is just digitizing a boatload of analog processes that just have sclerotic flow of information that create a ton of friction that gets in the way of access and transparency. And so, given that labor, people, paper, pens, fax machines, beds, buildings, pills, equipment, these analog physical things take up 90% of our resources, wow, digital can really replace that physical stuff with software. And I think take out, or help take out 30 to 40% of all the waste that, drives most healthcare today. So to me, that's like 90% of the value of digital is taking friction, waste, terrible information flow, to make what we already do better, smarter, faster, cheaper, safer, et cetera. The second is where digital comes in is on the other expectation you and I have is to be heard and to have trust. And that comes from how digital can unlock a completely different set of experiences for the patient and their family, experiences for the clinician, where they can show their screen side manners, their benevolence, how authentic they are, and just an elevated experience, which there really was not a great expectation of in analog healthcare. Digital unlocks completely new possibilities to meet people, what it will take for them to feel heard and to trust that they're going to get that action. And then the last kind of role of digital, which to me is like, so if 90% is taking friction and just operational stuff, I'd say 8% is a better patient experience. The last 2%, which frankly gets all the headlines and shit, and this is coming from a futurist, is digital allows us to do things in terms of action in healthcare, which is what we ultimately want when we outsource, that we could never do before in our analog world. These are the next generation tools. Certainly nothing we're really working on at Teladoc. We're just digitizing a bunch of analog things today, but 3D printing. Like imagine you're gonna have a little easy bake oven at your house and you'll print your vitamins and your pills for the day. AI that can do predictive medicine. That's a whole new body of medicine that didn't exist. Diagnostics that can do things that no human can do today or detect, and none of our analog tools can. So that's kind of the next layer of digital that I think gets way too much airtime, but it is important. So just in that context, I'll just lay out 3 points of what I think is the future of digital health in Canada, back to the thesis of today. One is from our vantage point, deploying around the world with leading health systems is the end of point solutions. I think everyone is tired of one-off individual subscale apps and tools and asking patients to cobble it together and asking health systems to integrate things. So, platform is the way to go. And just like patients can no longer be seen as a collection of diseases and body parts, us tool makers can no longer treat patients, and ask them and clinicians to stitch together all the individual point solutions. That's just not going to work. So every solution has to be connected to every other solution and bolted onto just a couple of platforms that'll emerge, I'd say, out of the box. And now that includes for the backbone of digital, of healthcare that doesn't touch the patient, but no more point solutions there. And wow, do we have a long way to go on that in Canada. The second future is, to Mark's point, is I call it care untethered. That's my new word for virtual care. That, we've tethered everything to these analog artifacts that are extremely static infrastructure, people, buildings, beds, laws, policies, and healthcare is anything but static. It's so dynamic. And so this, the new word to me is omni-channel, that we mix and match whatever way we need to get care to people, irrespective of static investments we've made in the past. Do you guys know Sweden invented a new word in their dictionary? They do about 30 words a year. In 2018, I'm going to put it in the chat, digiphysics. So they created a word to describe things that combine digital and physical presence because healthcare is digital. That's my English word of digiphysics. So this will just be normal, just like everything else in our life. And we won't have this binary alternative of the second orphan ugly cousin is a virtual exchange versus the real thing in person. It's just going to be seamless. So that's the direction we got to go. And then finally, digital will be normal. I think we will arrive when Mark Casselman has to change the name of his association yet again, because I think the days are going to be gone where we treat digital as this thing over there. I had the head of a health system write me to say, can you coach my virtual care center from our entire health system of what to do next? I said, why don't you get rid of the virtual care center? How about that? Because if we keep treating digital health or virtual health or m-health, e-health as this thing separate from health, that's inconsistent with the world we're in, which is a digital world. And so that's going to just become normalized, and digital won't be about tech or about things we pay for. It's just going to be an entirely new platform for healthcare. So I'll stop there and we'll get into some conversation.
I must say, I really miss being locked in a room with Zayna 2 hours a week, which I was for about four years. Wow. I will, Mark does, though, have to build capability, and we have had to build capability, Zayna. So I get what you're saying about needing to embed it, but how do we build capability and at the same time broaden it? I mean, maybe it's people have majors and minors, right? Like maybe doctors need to have a minor in it, and maybe that's actually where health informatics comes back. Comments?
And I just say it's like quality, innovation, all informatics that kind of is a permeated capability versus relegated to a department. I think that's the maturity model. I'm not saying it's going to happen tomorrow, but that's where we're heading.
Well, and I gather the quadruple aim is now the quintuple aim, so maybe it's the sextuple aim or something. Sonya, you're next, please, and welcome.
Absolutely. And Zayna, thank you for the digiphysic, because I think that's a really big theme here at Telus Health is we're digital first, but we're not digital only. And I'll talk a little bit about that strategy. So thanks for having me this evening. First panel for me at Rotman. Good to come back as an alumni. So really appreciate that. And what a panel indeed. And if you think about what we need to do to enable digital health, it's the silos that exist between, the factors that we represent here tonight need to come down, right? If we're going to move forward, there's so much work to be done to transform this healthcare system in Canada and globally, because while our borders separate us, the challenges of healthcare sustainability are precisely the same. So digitization, transformation, we all use the words. Very few of us understand the role we play in creating silos and interoperability being a secondary thought versus the first one. So I'll touch on all of that. But Will said, hey, Sonya, come, but you need to set the context of Telus Health because there's tons of questions out there in the ecosystem around Telus Health, what we're up to. I'm sure folks are scratching their heads on LifeWorks, the newest 7,000 employees we welcomed into the Telus Health family. So I'll touch a little bit about that as an opening and then get into some of the more topical conversations of tonight, if that works for folks.
Mhm.
So we'll start with Telus Health. So Telus Health was born roughly 15 years ago. So Telus, you may or may not know, has a big social purpose mandate. And so 15 years ago, our CEO, who's still our CEO, Darren Atwhistle, said, what are the big societal challenges that we're going to have to deal up in the next little while? And there were two: healthcare sustainability and food supply sustainability. Telus Health was born and Telus Agriculture were born, both still innovation arms of Telus today. So over the past 15 years, Telus has been very busy. I call it war chesting. So we've acquired, we've built this giant chest of digital products, services, and they all fit together in this beautiful ecosystem of preventative and primary care, but we haven't connected them yet. And so the next sort of phase of our evolution is putting all of these good pieces in their own right together so that 1 + 1 doesn't equal 2, but in our case, 1 + 1 equals 7. And so that's a little bit about what we're up to. LifeWorks was the newest addition to the Telus family, as I mentioned, employer-funded health and wellness, 160 countries, 25,000 employers being supported through what you call traditional employee assistance programming. So mental wellness, mental health, and financial assistance, et cetera, and really looking forward to integrating our products into that employer channel so that we create a new delivery mode of health and wellness services, prevention focused, into the channel that is the employer channel within healthcare, not just in Canada, but globally. So just a little sense of that. So if you think about what's in the war chest today, we have our electronic medical records. So 50% chance, if you've seen your doctor in Canada this year, it was on an electronic medical record that Telus provided. We service the pharmacy network as well. So chances are if you walk into a pharmacy, there's a 60% chance it's operating on a Telus software. And that's everything from just basic, what we would call transaction focused interactions, but really moving to enabling that community pharmacy to do way more with their patients today. Think about our virtual care platforms. We have a few of them. We have a virtual pharmacy platform. We have preventative health and wellness clinics, so bricks and mortar clinics, all the way from Vancouver to St. John's, Newfoundland, and Thompson, Manitoba. So bricks and mortar clinic. We have a really strong presence in occupational health across Canada. Someone recently said, why are you in occupational health, Telus Health? And I'm like, last I checked, we're in Canada, and we like to dig things out of the ground and cut them off the earth, and that's occupational health. So we got to keep our employees who are out there running this economy healthy and happy. So that's part of the occupational health mandate. And so if you think about where we're going next, I'll come back to digital first, not digital only. Employer focused, because someone has to pay to innovate in the healthcare system. We're hoping the employers and the corporations across Canada start to put their money where their mouth is, because they have a big role to play in how we fund this next evolution of healthcare. And, Mark hit on it. How do we invest? Last I checked, over 50% of every taxpayer dollar in Canada is going towards healthcare. I pay too many taxes. I'm sure everyone on this call does as well. Where is the investment coming from to feed this transformation? So one of my big pushes and questions is how do we unlock more investment, whether it be from government, whether it be from government equals taxpayer, remember, or corporations or otherwise. And really the three tenets, if I think about the three tenets that we're focusing on Telus Health and everything that we're doing to build this ecosystem is, number one, better information equals better outcomes. And so really what we've done as a telco is we facilitate the flow of information, right? All forms of it on a 5G network now that enables a lot of interesting things. In healthcare, better information equals better outcomes. How do we make sure we bring them to the providers? We bring them to the patients themselves. We bring them into the ecosystem in a safe and secure way. Another key risk in digitization of healthcare is security. So thinking about that very, very closely. And as Zayna hit the nail right on the head, it needs to be frictionless, right? So virtual care and in-person care is really just a modality to serve a customer well. And based on that customer's preference, based on that, what that customer's need is today, and call them a patient, call them a client, whether you're in preventative or you're in primary, that decision needs to be mutual between the provider and the client themselves to say, today is virtual, tomorrow is in person, and my data and information follows me in and out of the ecosystem as I use it. So think about that as that common frictionless experience. And then I think a really nuanced point here in what post-pandemic is delivering in the healthcare ecosystem for everyone is that you can't separate mental and physiological health anymore.
Mhm.
It's one and the same. Yet we've built health systems that have somehow separated them, that have somehow stopped funding elements of mental health, but continue to. And so what you'll see at Telus, and what you'll see as sort of a personal passion of mine coming from the mental health and addiction treatment space to Telus, is how do you create that integration between physical and mental health so that every interaction, whether it be digital or in person, is considering the whole patient. And there's tons of really neat digital health interventions on the mental health space, in the physical space, physiological health. How do we start just stopping that, right? How do we just make it whole patient care? And so really working on that as sort of three big pillars. And so my questions, I guess, provocatively today is, how do we start making ecosystem plays? Which I think, Zayna, you also commented on. So how do we stop having an app for that, an app for that, and the other app for this, and that app? What about one app, right? What about one digital ecosystem? Different channels, people can come in through different doorways, absolutely. But there's a networked effect that creates this ecosystem that a client or patient could come in and out of. I would say the second piece is perfecting that intersection between human and digital. Because one thing that anyone who's interacted with the healthcare system has noticed lately is the compassion crisis is a thing, right? Patient experience is not really top of mind for anyone, yet we know through the medical research that a patient's experience can impact their outcomes as much as the care that's been delivered. So how do we continue to push that human digital intersect in a way that fosters, enables, and pushes compassion back into the healthcare system? And I think with all the disjointedness that we have right now, we're actually creating a ton of spin in the client base because, as Zayna said, virtual care is bad care? Absolutely not. If it's delivered at the right time in the right circumstance, it's perfectly good. So how do we start having more healthy dialogues that don't make people skittish about the transformation that's underway in healthcare? So I'll pause there, open to questions. I'm sure I created a little bit more confusion around Telus Health, but happy to answer.
No, that was great, Sonya, and panoramic in terms of how you covered the different pieces. Just the same question that I asked Mark, but to you about TH. Roughly speaking, if you added 7,000, what's your total employee base at this point?
10,000.
10,000. So, okay. So that's a ton of people thinking about healthcare in one place in Canada. That's really
Absolutely.
impressive.
Yeah. And we're trying to have conversations around, we don't even call them health records anymore. We call them life records, right?
Yeah.
How do we allow information to flow seamlessly, whether it be a very basic EAP intervention, a very basic virtual care, all the way to something that might be more in-depth and meaningful as the patient progresses up the continuum of care.
Well, when I would kind of naively assume that with your size and scale, you probably have the ability to do that within your own ecosystem as well, which is interesting. Okay, Sacha, bring us home, and then we're going to go to discussion. Sacha Bhatia.
Thanks, Will. Yeah, super interesting conversation that folks are having. I think, certainly this is a different conversation than we would have had a couple of years ago when, the question that we had was, are people ever going to adopt virtual care? I remember those conversations years ago. And clearly, even in a system that is difficult to change, things like pandemics tend to do funny things to our ability to innovate. And I think virtual care was a good example of really what I thought was a pandemic response tool. I don't think there's ever been a moment in time where we saw such a rapid, adoption of virtual care across, obviously across the country. particularly, how ubiquitous that adoption was. So we have data that showed that, we went from, less than 1% of physicians using virtual care to almost all physicians, no matter their age or, what they did, used virtual care. So I think, and patients as well, cut across ages, cut across genders, cut across socioeconomic status. So all these tropes and questions about, well, who would use virtual care, this natural experiment actually demonstrated that actually, yeah, the uptake was pretty ubiquitous across patients and providers and pretty sustained actually. So, the other question was, in the pandemic, would we see a drop, once people were vaccinated, would people come back to the office? Would there be, basically a regression to the numbers that we saw pre-pandemic? And even if we continue to fund it, and the answer is no. We've been pretty consistent, above 50% for most of the pandemic. And now actually, we latest numbers in primary care probably demonstrate we're still about 70%, 65, 70% in person. And I think we've dropped to 30 to 35% virtual, which I think, frankly, Will and I would talk about this. And if we, in our wildest dreams, thought we'd get to 30% virtual, I think we would probably fallen off our chair in 2019. So I think, the reality is that there has been a pretty sustainable virtual presence in Canada. And oddly, Canada often gets criticized, by many of us on the panel, how slow we are to innovate and stuff. But actually, when you look across countries, the adoption of virtual care in Canada was actually higher than the US, was higher than Australia, was higher than a lot of other countries, and that sustains. So, the reality was there is, some pretty good data to show at a population level that this is a pretty sustainable trend, even into the pandemic. And, with many governments and payers are moving to codify virtual care in fee codes. Now, is this, the virtual care that Zayna talks so eloquently about? Probably not. It's really analog visits. But certainly there are, if you look across the country, even in Ontario, there are pilots around asynchronous messaging that's being funded. So, I have optimism around some of that stuff. What I would say, and maybe not to, not to be a downer about this sort of thing, but rather to sort of be a bit of a realist, is to say, okay, so we've all recognized, so virtual care is here. It's happening pretty commonly in any practice probably you go to in any place in Ontario. Someone will say, you will likely have access to virtual care in some form or another. So the question to me is, like, how does virtual care grow up? And I would say right now it's in a bit of the adolescent phase. It's had a lot of growth, had a growth spurt, 6 feet tall, doesn't really know how to use its body yet. And I think, there are a couple of questions that this rapid evolution of virtual care and rapid adoption has sort of led to. One, and I'll just sort of detail a couple of quick ones. One is, does virtual care lead to better care? I don't know yet. I think it can, and I think certainly the data that we, and I used to do research on this, demonstrated that it's not inferior for sure. But I think non-inferior is not what we're looking for. We're looking for better. And I think Zayna sort of talked a little bit about, the opportunity of the tool maker and the tremendous opportunities to increase innovation. But how is it actually happening today? Not in the future, in the high run, high quality practices, but in an average, family doctor's office or an average cardiologist's office. And I think what we want to do is we want to start to say, like, when should virtual care be used and how, in what circumstances, and what constitutes a high quality virtual care visit? And I think, I think that's an important question. And I mean, so I think we've been thinking a little bit about this on Ontario Health. and have been working particularly on developing some guidance, as of others, around what does constitute appropriate virtual care. I think it's really important. The second is, does virtual care decrease or increase cost? I don't know the answer to that yet. And I think, again, a lot of it depends on how you use it. I think in an integrated continuity of care related healthcare system where you have strong primary care teams and access to specialty care, an omni-channel universe makes a tremendous amount of sense in terms of being able to best manage patients, across a continuum, and virtual care makes utter sense, whether it be async or synchronous or whatnot, to be able to manage your patients. That to me seems like it would save cost. Some of the ways we've heard about virtual care being used, which is, in fact, one of my colleagues was had some abdominal pain, had a bone visit with his doctor. His doctor ordered an ultrasound. And my colleague, who is actually a very wise health policy costing person, said, shouldn't you examine me first? And I'm like, no, we'll just get the ultrasound. So that happened not infrequently. And I think there's a bunch of stories. And I will tell you that, practices changed in the pandemic, probably rightly so, because people didn't want to touch people or see people or put them in their office at the time. But, if that becomes the standard, which is the physical examination is replaced by a barrage of tests, that's probably not the best thing. And then the question around how do we actually, make this truly patient-centered? So I would say virtual care in its current form is pretty provider focused. What I mean by that is my secretary calls patients and says, you're going to have a phone visit with, Dr. Bhatia next Tuesday. But I don't think they actually ask them, are you going to do you want a phone visit, an in-person visit, a virtual visit? I think if they did, they would make sure that the unilingual Portuguese speaking person that I spoke to today would actually have come in person with an interpreter. And, the reality is that, or, people who are older, people who are frail, people who actually, for a variety of reasons would prefer to meet me in person, I think they have the option to meet me in person. And I don't think that that's explicit, that doctors are and administrators are saying, oh no, we won't do that, or won't do it if you ask, but often we don't ask. So I think, there's some really brilliant, doctors and researchers out there, at my old place, like Women's College and others, that are thinking about equity and thinking about vulnerable populations and how you actually use virtual care as a tool to be able to do this better and actually make it truly patient and not provider centric, because it still sits in that rubric, in my opinion, or in that paradigm of a very provider centric model. We've just made it so that you can take an appointment in your pajamas, but it doesn't necessarily mean that it's actually patient centered. So I think that we've got work to do, and this is not to be critical of virtual care at all. As people know, I'm one of the biggest proponents. I'm saying if we are going to grow past adolescence into something that looks mature, these are kind of the considerations that we need to take, because I would say now, people are expecting what's next, as I've seen in the chat. And I think it's really that maturity around, if you want to be treated like part of the healthcare system, well, then you've got to sort of answer and deal with some of those tough questions. So that would be my thoughts on this. And again, looking forward to this discussion.
Just so great, and you've wrapped it up and brought it back to the clinical side. But let me ask you, in your own mix at this point, in the patients you're seeing, whereabouts are you in terms of the mix, and how are you managing across modalities?
Yeah, it's a great question. So I guess I'm probably in the 60-40 in-person to virtual range. I've sort of set in my practice that I won't actually see new people on the phone. So that's just a personal preference. So what I will say is I do believe there's so I am not an anti-phone person. I'm actually a pro-phone person, because a lot of my patients tend to be over 70. That's what you get in the heart game. And the reality is, a lot of them, it's much easier. And a lot of them, in my practice, come from a distance, and internet connection and things aren't that easy. So, I think phone is still a reasonable option in the right circumstances. So I would say my practice is new patients I see in person or by a video link like Teams or whatever. I do still believe in putting your stethoscope on someone's chest when you're a cardiologist. So I do try to see them at some point if I'm building a relationship and have and do a physical examination on them. I still think, call me old fashioned. I think that's important. And then what I do is after that assessment, we decide, together, what's the right, next visit. Is it if it's honestly a 35-year-old who I've met who's got chest pain, I'm going to do a stress test on them and I just need to give them the results, I'll do it over the phone. I think that's pretty reasonable. If it's something that's a bit more complicated, I'll bring them in person or I'll do it over
I'm going to
the phone.
ask this to Sacha, and then anyone else who wants to jump in can do. But Sacha, how do you actually assess social determinants and what I'm increasingly heard called digital determinants when you assess what the modality that might be appropriate is? I mean, you gave the Portuguese language example, which is a good one, but how do people, and I guess Zayna or Sonya, you may want in on this. How do you guys assess what the right modality is if you're running these multimodal systems? Sacha, do you have a rule of thumb?
Personally, it's a great question. I don't think we do it well. I use my own clinical judgment and experience, which is why I say I want to see people first. And so I don't think, I'm going to be honest, I don't think that should be left up to the discretion of the physician. I think it should be, something that good systems will build checklists for about people's competence and capability. I think we need to tell people what their preference, we need to give people options about their preferences. And I think, to be honest, I think then there's a clinical angle to it about what's appropriate. But I think we need to have some clinical competency that's built institutionally to be able to make that assessment.
But by the way, the chat is exploding about translation services. At least 3 are listed. So you might want to get women's on one of them. Just for fun. Sonya, you wanted in on this? Go ahead.
I did want in on it, and it's the human digital piece. I'll bring it back to that. That patient choice has to rule the day in how they engage with the healthcare system. And I agree there are elements of virtual and digital care that become provider centric, right? And all of a sudden, we're seeing it a bit in the primary care milieu right now, where women who need pap smears can't get them, right? Because everyone's working from home. So I think, to your point, Sacha, there needs to be some guidance to providers for sure, so that we again have a balanced view of what access looks like. But I think first and foremost, given what the healthcare system is built to do, take care of people, we need to take an individualized approach to how we provide access to folks. And that's where team-based practices come in, multidisciplinary teams. So if the doctor is not on site, they can still come into a clinic and have a physical interaction, but maybe the doctor is on a screen. But it's that concept of, if they feel more comfortable being seen, being touched, then that's what they should be able to do. And only when the physician or provider says, something's up, then you should start to direct and work through behavioral and motivational tactics to get a patient to change a behavior because it's better for them.
I'm going to let Zayna in, but I want to point something, and Mark too, evidently, but I want to point something out that both you and Sacha, and frankly, everyone does this all the time, including me. You both have fallen into what I'm starting to call visit replacement language. And visit replacement language is, we have this mythical thing that we used to do, which was the physical visit, preferably, with Marcus Welby. And now we're going to replace it with a video visit or an audio visit or an async visit, but it's visit replacement. And I don't think that's what we're really talking about. Is it, Zayna?
No, I'm on a obsession to emancipate from visits as the currency of healthcare. That's such an old industrial model. But again, to Sacha's point, that's the maturity level of Canada. Visits should be, I think, about 10% of the care exchanges in a true good care experience. That's what leading health systems are at. And so sure, when that thing happens, you can do all the things and figure out how you want that visit to go down in a one-on-one binary. But digital health, why Mark has how many thousands of members in his group, and is about digitizing so many other things than this thing called the visit, right? That's where the value will get unlocked from digital healthcare.
Yeah, and that's really what it's all about, because when you talk about these multimodal exchanges and ideas, it's at the system level. I mean, we really need to move and migrate from this old model thinking of how we invest in building healthcare systems. It goes back to that conversation Zayna and I were having. Is it 3% or 4%? It's none of those. You know, it's banks and retail are getting much closer to us now post-pandemic, because they have the very same challenge we have. They're looking and saying, we have to provide a multimodal environment to provide access and value and all these elements. How do we manage the investments? If we're building multimodal digital, we're consolidating physical, we're bringing spaces together, we're doing these things. And importantly, it's premised on decisions that require CFO, digital transformation, clinical ops, all at the table together, building that environment.
Well, okay, I buy that, but if I'm running a clinical trial to see whether one modality is better than the other modality, then I need to randomly assign people to the two modalities and run a trial, right?
Well, if your focus is clinical efficacy, for sure, but we're talking about service delivery at a much bigger window here, I think. That's part of it, absolutely.
Just pointing out, I'm pointing out the logic trap that we're all fall into. And by the way,
we're there.
I pushed Sacha and Sonya on it, but frankly, I've been falling into it in my writing for months now. It's really interesting though, because when you deconstruct a fee schedule, like if you look at the Ontario PSA, right? That visit replacement logic, Sacha, I'm going back to you, and then Mark, be prepared. We're going to discuss the demon of interoperability here in a moment. But you know, Sacha, you think about the logic of visits, right? In the PSA that was just announced, the PSA is a physician services agreement between the government and its physicians. And you think about that less valued visit, right? Oh, it's only worth $20 if you don't have a pre-existing relationship. Well, what if the patient doesn't have a primary care doctor?
Yeah,
then
no,
worth 40? Is it worth 40 then? Because it's, sorry, go ahead.
Look, yeah, I mean, look, you know, I could go on for a long time about the PSA, and obviously, you know, there's a, you know, look, I'm fully believe that, you know, a fee-for-service system isn't necessarily, you know, the ideal mode of way we should be paying for the delivery of continuity of care in healthcare, for sure. We have a long way to go from there to get to where, you know, Zayna and they want to go. Requires a tremendous amount of political will. And remember, all these things are negotiated, right? Between, you know, it's not you know, the government can't do these things unilaterally. It's clearly negotiated with the physician association. I think, you know, what my guess, my best guess, is that many of these things were compromises, right? Around, because I think one of the challenges, and again, one of the negative parts in virtual was the experience a lot of patients got, especially among community specialists, and I can say, you know, and some of my colleagues, where it was like, I never saw, and I'm sure you heard this, I never saw my doctor, I spoke to them over the phone, and that was basically it. And without a pre-existing relationship, it didn't actually feel like they got care. You know, they spoke to somebody, you know, they never got examined, they did a few tests, and then they heard that, yeah, everything's fine or everything is not fine. And I think it's difficult to explain to a patient, even though for my colleagues and even though for myself, I'm like, yeah, actually, we provided adequate, competent consultative services. It's difficult to explain to a patient that they got care in that circumstance, right? And so, you know, I think this is the question around my original question was, what is high quality care, right? And what is it from the patient perspective? I think this is where prems and proms would be really great. And to understand from the patient's perspective, like, did they feel they got care? And I think the negotiation of the PSA around that really was trying to say, we need to be thinking about what good quality care and continuity of care was, admittedly in an imperfect compensation model.
Okay, so look, we can toggle between a visit replacement model or a more comprehensive model. We probably have to do both for a while as we grow up. But now is that time in the conversation where we have to talk about interoperability. And,
No.
and Sonya, you're running like half of the physician desktops and 60% of the pharmacy desktops. So obviously you've solved interoperability for most providers. Or Mark, was that you who solved interoperability because you got all of your group, your members together and you agreed on some reasonable standards that we're all going to adhere to? Did you
Yeah,
solve
well,
that, Mark? Or sorry, who wants it?
I was going to start by, the old adage, you can't eat an elephant in one bite. And, to say that Telus has solved it, even for the solutions that we run, would be an overstatement, because medical data is complex. Interoperability is challenged. Security to where it is today, where it needs to be before we start intersecting data sets and putting them in the cloud, et cetera, et cetera. I mean, those are the investments we're making now. So I would say they're foundational to allow us to again, share data across providers in a very secure and safe way. If we look at Prescribe It, what they've been doing, right, trying to bring all the data up and pull it back down. The challenge is we have, many, many provinces, and Mark, this is where you need to come in, that want to build the exact, they're trying to solve the exact same problem, but they want to do it 10 different ways, 11 different ways, 12 different ways. And it is slowing us down, and it is killing us. The red tape, the bureau, like Zayna said, just tear up the policy, tear up the regulations, let's go. That is our biggest barrier right now, is we all have the same problems, but we're solving them in silos. And so, we're trying to control our ecosystem within Telus to prove concept of the value of interoperability for sure. And then hopefully push that knowledge as quickly as we can out to the broader ecosystem. Ecosystem small, easier to create smaller ecosystems and then build bigger ones would be my direction on this.
Mark, do we have to solve interoperability to have seamless care to realize your vision of omni-channel?
Well, it sounds like a wicked problem. Well, listen, I think at the end of the day, there are so many experts out there and so many, groups that have got this in place. It does come down to legislation and regulations and some management decisions or some political decisions, as Sacha put it well, political will to make a big move in one way or another to be able to do that kind of national connectathon, connecting across all these systems.
So Mark, do you think it's time for Minister Duclos to put the hammer down on this?
Well, I don't know if it's time to put the hammer down on this particular, from a legislation regulation standpoint. I'm honestly not the expert, Will, in this space on interoperability to speak to that. But
I was interested to see that the Competition Bureau has now gotten involved in this, and that they have issued a report in late June, early July, on how they're going to regulate systems. Those of you who follow the US will be aware that something that looks a lot like the Competition Bureau has been doing similar stuff in the US. So I tend to agree with you. Does anyone want to tackle this about what the next step is in interoperability? Because politely, we've been chewing on this elephant for at least 25 years now.
Look, I'm not a technologist at all. My view is like, they'd be like us having a debate right now, like, how can we get people to make apps that work on iOS and Android? They just do. So to me, like, you just interoperate. If the plumbing isn't there to no matter what the system is, and there's very good standards, you're kind of not going to be able to make it. And that's definitely been our experience on the ground. Literally, while you guys were talking, one of our customers wrote me and they're like, can you interoperate to this EMR I have never heard of before? I checked, yeah, no problem. It'll take about 3 weeks. It'll cost $25,000, done. It's not, I don't think, as big a deal as we're making it out to be anymore.
Transparent pricing of interoperability. Yeah, I agree with that. Anyone else on this? And then I'm going to ask one final question that I've been seeing in the chat and wrap up. So just so people know. Anyone else on this one? Okay, well, I did interoperability, so that's good. Sonya said someone has to pay, and you hope it's going to be the employers. And there is no doubt at all that this mid-level provider community of things that have been being provided by insurance just took off during the pandemic. I mean, a lot of people turned to their employer-provided care. What's striking is that the public system seems to only pay for higher price solutions, pays for physicians, it pays for hospitals. And the employers seem to have all the mid-level providers on their side. How are we going to ever get to a comprehensive system if we start paying for different providers from different pots of money? How's this going to come back together again? I mean, I think I'm going to use if we want an integrated orthopedics pathway, we have to have physiotherapists and orthopods on the same payment system, don't we? Sacha, go ahead.
No.
No?
Okay. No, I mean, yeah, for sure, right? That would be easy and simple, and great. I think obviously, I think payment reform is critical. I've often said that you know, the way that we got virtual care to be adopted beyond the pandemic was we paid for it, right? Like we funded. So if you want to do this, you know, funding is a really important lever, and obviously bundling care and I've always said, I think government and payers should be responsible for the what, and providers should be responsible for the how, because healthcare is different and local circumstances are very different. And so what works in, you know, in some cases, you know, obviously there's some standardization, but there are local delivery, especially in digital, there's local delivery nuances that I think are important. But, you know, getting to fully capitated, bundled payment reform is exceedingly challenging in Canada. And I think the way to do it is demonstrating, you know, what I would call a ruthlessly incremental approach. So you're constantly trying to move, you know, the needle forward on bundling more things, creating more integrated funding models, you know, being able to think about, you know, creating greater degrees of capitation in primary care, which we're doing in Ontario, and you know, demonstrating value from those. Because, you know, that's the other thing that we have to constantly keep thinking about is how are we actually showing patients and providers the value of what we're doing, of our policy moves. So we have to demonstrate value in each of these stages, and again, constantly, ruthlessly, incrementally move forward.
Sonya?
Yeah, so two things. Globally, 60% of healthcare funding is spent on treating people when they get sick. 2% is spent on prevention. So we think about the role of the employer in that model, Will and team. The way that I view it is if we keep people healthy, the 75% of people that walk around the streets of Toronto or whatever city you're in every single day that don't think about lifestyle choices, that don't think about exercise, that all of those things, how can employers engage them in health in a different way? How do we focus the employer on preventative health and wellness? Maybe early triage and primary care, so that we don't end up spending all our money treating people with preventative illnesses. That's the intersect for me.
Sonya, the issue with that is that then leaves the employer group, the employees are by definition less, include fewer marginalized populations. And there are going to be huge numbers of marginalized populations left out of that model. Doesn't mean we shouldn't do it, but then who picks up the who does wellness for the people who need it most?
So again, I don't think this is one payer, right? This needs to be a multifaceted solution. So if you think about what Telus has in our Health for Good, we have 16 mobile vans that go out and do exactly what you're doing. It's a not-for-profit, it's a charitable engagement. Lessons learned in the employer space are being applied there. That's again, you know, charitable organizations doing it. Our company, Telus, investing in that. But there's ways to get more services in if we partner differently. Because again, think about what employers have to think about. Number one, they need employees, right? They need them to show up. They need to be happy, productive, and healthy. they also have to have cities that surround their offices that are functioning and well. And so I think there's just something there that we can tap into, either charitable giving and or the employer space, to fund more money into the healthcare sector. I don't think it's the solution, though. The solution comes back to a concerted effort where everyone is contributing, and that will change year over year based on how far advanced one space may be or the other.
Okay, you guys have been great. I'm going to start with Zayna and Mark because they weren't in on the last question, but I'll give anyone who wants it a final shot. We have lost 10 members of the audience, even though we were scheduled to 6:15, and that's always depressing for me. So if people are leaving, we're going to just wrap it up. God damn it! So Zayna, you got the first shot. Go ahead.
I put my mic drop quote in the chat, which I think sums up to me the ethos of this. I think maybe 2 points I'll end with. I think we, just like we can't tether ourselves to telephony or video or before the fax machine, we used to say a thing called radio medicine. I think we have to be really careful to make sure we're always thinking technology agnostic or modality agnostic. You hinted at it, Will, but I get really scared by the way I'm seeing policy being done. We're going to be locked into technology that will obsolesce in a couple of years. And then we're back to fax machines, which are still alive and well. And then I just think we got to, all of us, as we're trying to create the future, be obsessed with the problem, be obsessed with the outcome. The goal of healthcare is health, and be very, very flexible about the solution. And I think we love to do one size fits all solutions, and that's what gets us in the problem we have today. Awesome discussion, everybody, and great questions in the chat.
Mark, final shot.
Final comment, Will, is it's all about people. So look, we've talked about technology, future visions, financing, business models, how systems need to be redesigned. But it's amazing because digital health, I go back to my earlier point, it's all these multidisciplinary domains. And our clinician colleagues are challenged. They're hurting, they've pushed through a tremendous amount. And it's really critical that as systems thinkers and technology people looking at data and devices, all these other elements, we really take that into consideration as we plan ahead, as we try to engage and as we try to implement on the ground across all healthcare settings, from community all the way to hospitals and back.
Cool. Sonya?
I just wanted to thank everyone for a fantastic conversation, and anyone email me if you're confused about what Telus Health is up to, because we as a team here at Telus Health need to get out and partnering better and more effectively. And again, happy to share any knowledge that we have. We've made tons of mistakes and we make them every day, but happy to share them regardless.
Sacha, last word to you. You're muted.
Just thanks for the discussion. It was a really enjoyable talk.
And thank you guys, you've been great. And thanks to the audience. We're back again on November 2nd. We're talking AI with Avi Goldfarb, who is one of a team that has a new book. Their first book was Prediction Machines